Are there more than one type of prostatic cancer? Different types?
Prostate cancer usually is a glandular type of structure.
Right.
And the interstitial or the stromal type of cancer is usually very unusual. And most of the time, you being a pediatrician, you'll see it in children. They have sarcomas of the prostate. They're very unusual. Most of the aging prostate will get an adenocarcinoma, which means glandular structure.
If we make the diagnosis from needle biopsy, what's your next step?
Okay. The next step is after that thing, there was an individual by the name of Dan Gleason. This person was the one that developed the type of score. And anything that they have tried to do to knock this thing down from the 70s when he came up with this, nothing has worked. They tried DNA, they tried flow cytometry, they tried everything. Nothing is as good predictor as the Gleason score. So the Gleason score is what they're doing is they're taking the best part of the cancer and the worst part of the cancer, and it's a sum. And it's each one of them is between 1 and 5. 1 being the least aggressive type of tumor, 5 the most aggressive type of tumor. What's the majority of the glands? The majority of the glands figure it's a Gleason score 3, depending on the cellular type of structure. Then you take that 3 and you put 3 plus. And then you take the other part of the tumor that is the least amount of tumor what you have, and you also add the number. So if the least amount of tissue of tumor is figure another 3, then you get a 3 plus a 3, and that's a 6. If the least amount of tumor is a 4, then you get a 3 plus a 4. Now, Gleason score up to 6 is usually a moderately, up to 4 is a well-differentiated, 5 to 7 is a moderately differentiated, and 8 to 10 is a poorly differentiated carcinoma. The recommendations from the AUA is that anybody that comes down with a Gleason score up to a 7, you have to tell them that no matter what you're going to do, you're going to end up with the same type of result, including the watchful waiting. Watchful waiting indicates not that you're going to get lost once the cancer is diagnosed, but you can sit tight, go back to your urologist every 3 months, get a PSA, and get a digital rectal exam. If your PSA starts climbing, or your digital rectal exam indicates that the nodule has grown, or you're starting to develop some symptoms and difficulty in urinating, or this is obstructing, or you're getting an infection, or you're bleeding, then you should be treated. Now, the life expectancy on this person is usually about the same, no matter what you do. And there are many options that you can take. One is the watchful waiting that we just said, and most of the people are usually taking the watchful waiting. But you have to have the stomach for it. A lot of people feel very nervous knowing that they have some kind of a malignancy and not going to do anything about it, except to watch it. That's what they do in the Scandinavian countries. They just make a diagnosis. They don't treat anybody. And they watch them, and they see what's going to happen to these people. And they know that anybody that has a Gleason score up to a 7 is going to live 15 years, about 85 to 90% of those people, without doing anything whatsoever. It's not the same to say of somebody that has a Gleason score 8, 9, or 10. Those are poorly differentiated carcinomas. The recommendation is also, any treatment is just the same, except surgery indicates a little bit of an advantage over the other procedures.
Not a big event, just a little bit.
Just a little bit.
Sometimes you get very good results with surgery.
You get good results with surgery when you're dealing with a poorly differentiated carcinoma. If you deal with somebody that has a Gleason score up to 6, and you know that if you're going to do nothing, and that person is going to live for another 15 years without doing anything, now I'm going to give him surgery, and you have to consider the possibilities and the complications of surgery. And those are usually incontinence, which is basically total incontinence up to about 5%, and partial incontinence, which means a mixed incontinence between urge and stress. It means when you cough, sneeze, you lift up, you change position, you start leaking. Those people that the partial incontinence goes up to about 30 or 40% of those people. And then the possibility of having positive margins, which means that after you remove the prostate, if the tumor has grown beyond the area where you have resected, you still have to treat with further treatment for these people, even though that you have operated on them.
What about chemotherapy?
Chemotherapy is one of the treatments for cancer of the prostate. However, it's not that much popular. What we're doing for this thing is, rather than the chemotherapy right off the bat at the beginning, we're giving him androgen ablation therapy. The work of Dr. Higgins demonstrated that the testosterone, which is the hormone produced by the testicle, is the one that stimulates the growth of the prostate, is the fuel for the cancer of the prostate. So if you cut down the testosterone production, and the initial treatment used to be take the testicles out. Whenever you made the diagnosis of anybody of cancer of the prostate, automatically you get castration. By castrating somebody, you're taking away 9/10 of the entire testosterone production. The other 10 is produced for the adrenal glands, which is the gland that is above the kidney. That produces about 1/10. And that's inhibited by a different thing. So after they came out and they did this radical thing by taking the testicles out, it was the cheapest though. Then they came out and they discovered other medication, which is called the RH-LH analog, which is the medication that everybody knows, which is Lupron and Eligard. Those medications, what they do is by giving it to somebody, you're going to cut down the amount of testosterone. And the testosterone will go to castrated level, which is basically under 50. And also you're going to watch the PSA going down very rapidly. After 3 months, normally the PSA goes down almost down to 0. And the size of the prostate is cut down in about almost half.
So in other words, if you're in a situation like this, you should sit down with your urologist or anybody else involved in the decision making with you. It's when you find out that your options in terms of life expectancy and quality of life have to be taken into consideration, and the final decision is you better make it with a lot of good guides. And you made some pretty good points here. So in other words, benign neglect is probably the treatment of choice most of the time. Right. And you're talking doing something to control the hormone that maybe stimulates the growth. Is that correct?
Right. However, the hormones are not without any side effects. So basically not anybody that gets the diagnosis of this thing, you're going to give him an anti-hormone type of therapy. Because basically they have shown that people that you give them this medication, they start feeling lousy, they get the hot flushes, they lose muscle mass, they start getting fat, they gain weight, they get sleepiness, and they get tired. They can't work as well as whenever it is you lose the stamina, because your stamina is mediated by the testosterone, which is the male hormone. And if you're cutting down the male hormone, you're castrating somebody. It's called medical castration. That is usually not without risk. And the other major problem is that usually cuts down on the minerals in the bone. And they have shown that everybody that gets this kind of medication, within 10 months they develop osteopenia, which is diminishing of the calcium on the bones, and osteoporosis, which means basically a depletion of it. It's
so they can get stress fractures?
They get stress fractures, and since they have, this thing is not a urology study, but it's an orthopedic study, and they show that whenever you get a fracture of the hip, it cuts down on your life expectancy. So these people may develop some fractures, and they get bone pain, and they get back pain, and it's usually associated with this. Plus, your desire for sex is gone, and your ability to have an erection is gone, and your ability to have an ejaculation is gone.
So in other words, it's not an easy decision.
It's not an easy decision. So therefore, it's not recommended to anybody. It's usually left for people that have a diagnosis metastatic disease or develop metastatic disease during their treatment. Metastatic disease, that means the spread of the disease. And usually this thing spreads to two things. It spreads to the bones and it spreads to the lymph nodes.
Is it true that someone once said to me, if you live long enough and you're a male, you'll get prostatic cancer? Is that true?
Eventually. They have done some studies on people that have died from automobile accidents at the age of 50, and approximately about 40% of these people have cancer in their prostate, which is basically something called non-significant carcinoma or insignificant carcinoma. It's a small amount of low grade that will never give you any kind of a problem. So therefore, the watchful waiting would be an option. And those people, if you get the diagnosis by doing a needle biopsy, having forced a needle biopsy on these people, then now all of a sudden, one of the things you have to do is maybe you have to treat these people when basically there was no need to treat them, because they're going to get some carcinoma of the prostate, which is completely indigent and indolent, and it's not going to give you any kind of a problem in the long run. However, a lot of cancer of the prostate is being diagnosed every single year in this country. Approximately about 190,000 people come down with this disease, and still people die from the disease. About 30,000 people will die every year from cancer of the prostate. So you have to take everything with your doctor, discuss it very well whenever the diagnosis is made, and be evaluated by somebody.